All right, so today we are going to talk a little bit about, after doing blood pressure and everything else here, we're going to talk a little bit about how blood pressure and the other force of osmotic pressure are going to influence the exchange of different substances at the capillary beds. Again, most of what when we've been discussing the whole purpose of the cardiovascular system, it really is to deliver substances to these capillary beds where this exchange can take place. Uh, Again, a lot of how things are going to move in or out of the bloodstream is going to be very dependent upon really those factors that how things get in or out of cells in general. So things like diffusion, things like osmosis, and then some of those bulk transport mechanisms using the vesicles. So again, a lot of your nutrients that are permeable through these blood vessels, things like oxygen, things like different hormones, things like different nutrients are going to, for the most part, move through that simple diffusion. This idea of things moving from higher concentration to lower concentration. And because, again, things like oxygen are going to be picked up at the lungs, going to be at higher concentration when they get to those tissues, they're going to move with that concentration gradient. Same thing with carbon dioxide. It is being generated in the tissues. It's at much higher concentration in the blood, in the tissues than in the blood. So it's going to move with that concentration into the bloodstream. So again, most of our nutrients, because they're being picked up in different places, are going to be leaving the bloodstream at the capillaries and going into the tissues where they're being used up. And most waste products and things like carbon dioxide that are being generated in the tissues are going to be in higher concentration there and generally will move to the blood. Some of these things are going to move through the cells. Some of them are going to move in between cells. So things that are small will go in between endothelial cells, in between the clefts between the cells. And some of these things we're going to have these larger gaps in there. So those fenestrations or sinusoids that we talked about in class, they're going to be passing through those gaps. There is certain things where it's not capable of going in between the cells or through these sinusoids. So in some cases, we're going to use vesicles to move things in or out of the bloodstream. So the vesicles, either using pinocytosis or endocytosis, are going. Pino is going to be with the fluid, is going to take vesicles on one side and move those from one side of the cell to the other, and then let it exit in or out of the bloodstream. And like it says, certain, like it says on the slide here, certain hormones, certain fatty acids are, especially fatty acids, it's really how we absorb them. For example, in the digestive tract is through this vesicular transport from the lumen of the intestines. It's going to take those through a vesicle, move them through that cell and into the bloodstream, or in a lot of cases into the lacteals, which is a lymphatic capillary, which sooner or later gets returned to the bloodstream. And again, these are going to be these bulk flow mechanisms, these large amounts of either fluids or substance moving one direction or the other. One of the things that we definitely need to worry about the bulk flow of is really this idea of liquid and water, for example. We're going to see these bulk flow mechanisms at the capillaries. We really have a couple of competing forces that are going on there. We have what is called hydrostatic pressure, which, if you really think about it in the blood vessels, it's water pressure, which in the blood vessels is technically blood pressure. And that is going to be working against what we call colloid pressure or colloid osmotic pressure, which is that flow of substances of water, technically, moving one direction or the other to try to balance out the concentrations of dissolved substances that can't leave the bloodstream. And really how this water is going to flow overall is really going to be played out in the math of how these values are at one part of the capillary versus the other. So filtration is really this idea that we have a particular blood pressure, a particular fluid pressure or hydrostatic pressure, and this pressure, when it's higher, is going to push fluids out through openings in between the capillaries, between the walls and the capillaries, and push these fluids out. what we've kind of said in these other slideshows is that your pressure is on a gradient from the arteries to the veins, and your highest pressure is going to be closest to the heart, and your lowest pressure is going to be when blood is entering back into the heart in those large veins. What this kind of means is you're going to have a gradient at your capillary bed where you're going to have a higher hydrostatic pressure at that arterial end of the capillaries because it's closer to the heart and the pressure is higher. And as you work through that capillary bed, it is going to decrease as we work our way through. So filtration, we're going to see, is going to be much higher and is going to be occurring more at the capillary bed. That osmotic pressure or colloid osmotic pressure is going to be pretty consistent throughout, but what we're going to see is because that filtration pressure is going to drop as you work your way through the capillary bed, we tend to see a lot more reabsorption or osmotic flow happening on the venous end of that capillary bed. And again, we start dialing this in a little more, and in reality, it's really kind of with both of these competing pressures of both. So there technically is the blood hydrostatic pressure, or the actual blood pressure within the blood vessel walls. So that is that blood pressure, how much is pushing on the wall. This blood hydrostatic pressure is going to promote fluids leaving through that filtration idea. There is a little bit of, there is fluid that is around these cells in the interstitial areas, the interstitial fluid, that tissue fluid. Technically, if it were to build up in that area, there could be a force there. But what we're going to see is in millimeters of mercury relative to the blood, generally this is a zero pressure. There's not pressure there. Obviously, if there was a lymphatic backup, there was edema happening, that might not be true. But under normal physiologic conditions, that should be about zero in there. So we're going to see hydrostatic pressure is going to be favoring fluids leaving the bloodstream under these conditions. This colloid osmotic pressure, this is those dissolved substances, those things that can't leave the blood. So in terms of the blood cells, albumins, what these are going to do is generate an osmotic gradient. Generally, we're going to see the blood osmotic pressure is going to promote reabsorption, and it tends to stay pretty constant throughout. It's going to oppose that hydrostatic pressure, generally is going to promote reabsorption. If there somehow was more proteins present in the tissues, that osmotic pressure in the tissues, this interstitial colloid osmotic pressure, it could draw fluids into the tissues, but generally what we see is most of those proteins are absorbed into the cells, and because of that, there is very few proteins in that tissue fluid. So what this really means is generally that is a very low value in terms of that osmotic pressure, and generally is going to, what it means is between these two competing forces here, the blood is generally going to be trying, because it has a lot more dissolved substance in it, trying to reabsorb fluid, where because there's very few proteins present in that interstitial fluid, it is not. So that reabsorption into the bloodstream is going to be favored. So what is the difference between these hydrostatic and osmotic pressures? The hydrostatic pressure is the force pushing those fluids out in the blood vessels. Generally, like I said, there is a competing tissue on there, but it's normally zero, where this osmotic pressure is really going to be favoring, if under normal physiologic conditions, a pulling of fluids back into the bloodstream. Again, more so at that venous end, and we'll look at all this with some numbers in just a second here. So this little chart is giving us a lot here. You can see here, this is the artery coming from the heart, the arterial here. So if this is a simplified capillary bed. We're just doing a single capillary, kind of doing this, but in reality, we know we have a whole bed of capillaries here. But what we're saying on this one little vessel here, it kind of fits for all those. We can see on this side here, we have the venule taking blood back to the heart, so the venous end of this capillary bed here. What we're kind of seeing is the competition of these different forces on each of those here. So we've talked about that hydrostatic pressure and what it's doing at that arterial end. We kind of talked about how we had the hydrostatic pressure of the blood versus that interstitial fluid. We said under normal physiologic conditions, that hydrostatic pressure of the blood is going to be about 35 millimeters of mercury. And under normal physiologic conditions, the interstitial fluid really doesn't have much of a hydrostatic pressure. So if we kind of do the math on those ones, kind of the hydrostatic pressure pushing fluids out versus the hydrostatic pressure pushing fluids in, we can see overall net hydrostatic pressure really is mainly generally just the blood vessel hydrostatic pressure. So it's going to be about 35 millimeters of mercury pushing fluids out at that arterial end of the capillary. If we look at the osmotic pressure, like I was saying, there is a lot more dissolved substances, a lot more stuff in that bloodstream than there is in the interstitial fluid. So we can see on average, in the normal physiologic conditions, we're drawing about 26 millimeters of fluid back in due to that blood osmotic pressure. Working against that is that colloidal osmotic pressure of the interstitial fluid, which is about 5 millimeters of mercury. So if we do the math on that, we can see overall at this arterial end that net osmotic pressure drawing fluids back in is about 21 millimeters of mercury. What this means on at this arterial end, in terms of bulk flow of fluid, that hydrostatic pressure is much higher than the osmotic pressure. So at the arterial end, if we're kind of just doing under normal conditions, and again, I'm not super worried about the numbers. I'm not going to test the specific numbers of what's going on here, but you need to understand the basics of what type of flow is going to be favored. But if you kind of look at the math here, that hydrostatic pressure at the arterial end, that pushing out fluid pressure is about 35 millimeters of mercury. The pulling back in is only about 21 millimeters of mercury in terms of pressure. What that means is we have a net flow pressure out of about 14 millimeters of mercury. What this is saying is the bulk flow of fluids at that arterial end favors fluids leaving the bloodstream. Again, this is a gradient. So at the arterial end, pressure is going to be higher. As we work our way through that, as you can see the cursor going across here, as we get to the arterial end, we know pressure, that hydrostatic pressure as it works through the capillary beds drops. If we start looking at what's going on at the venule end of this, we can see that net hydrostatic pressure is going to have dropped because at the arterial end it was about 35 millimeters of mercury. As we get to the end of the capillary and we're at this venule end now, we can see the overall blood pressure has dropped, so that net hydrostatic pressure of pushing fluids out has dropped all the way down to 16 millimeters of mercury. Again, we do not have much in the way of hydrostatic pressure in the interstitial fluid, so our net flow out now is reduced all the way down to 16 millimeters of mercury. Because those albumins and other things do not leave the bloodstream, we get a pretty constant throughout this capillary bed level of osmotic pressure. So what we see now that we're at the venule end, we still have that 21 millimeters of mercury that is drawing, that net pressure drawing fluids back in at the venule end. But what's changed now is because the hydrostatic pressure has dropped, we can see that net osmotic pressure now in the bulk flow of fluids, it is favoring a flow in now because we actually have this 21 millimeters of mercury is higher now than this drawing in fluid is higher than the pushing out pressure. So what we have now on this venule end is about a net of about 5 millimeters of mercury drawing fluids back in. What this is doing is meaning that the actual flow of water at the venule end is favoring going back in. One of the things I do want to point out on this is that the net flow at the arterial end is much higher than the net flow going back in at the venule end. What this kind of means is if everything was left to its own devices and this was the only way we were getting water in or out of the bloodstream, we would, over a very quick period of time, push a vast majority of fluid out into the tissues because this net flow in and net flow out are not equal. What we know we have going on here and why we have one of our body systems is the lymphatic system. The lymphatic system, at least the system of vessels on it, is picking up this excess tissue fluid and through a system of vessels returning it to the body at the subclavian veins right as you are getting close to the superior vena cava. So the fact that these are not balanced is being compensated for by the lymphatic system returning that excess fluid to the bloodstream so we don't lose it. The other thing I want to kind of mention on this slide, and I know it's been a while on this one slide here, is again, this is under normal mean arterial pressure conditions. If you are having high blood pressure, this number would be higher, which also means this number would be higher, which means you're, in the case of high blood pressure issues, if your mean arterial pressure has jumped up a little bit, and let's say it's 45 here and 26 here, it means you're still pushing more fluids out than you're drawing in at that venule end, which again, if you're not having edema, means that your lymphatic system is having to compensate for that. But that is part of the reason that somebody with high blood pressure is going to be at a higher risk for edema if for some reason that lymphatic system was not able to keep compensating for that increased push of fluids out into the tissues. So I think if I remember right, the next few slides here are kind of doing what I did on that whole slide in words here, just kind of again showing you what is the net hydrostatic pressure, what is the net colloid osmotic pressure. So the net hydrostatic pressure is the difference between that blood pushing out versus the interstitial fluid trying to push fluids back in. This one was about 35 at the arterial end. This was 0. The net colloid osmotic pressure, that is the difference between those dissolved albumins in the blood that are trying to draw stuff back in versus dissolved proteins in these interstitial fluids that are trying to draw fluids out of the bloodstream. We know this was about 26. This one was about 5. So we had a net, at least throughout the capillary bed, about a net 21 of that pulling fluids back into the bloodstream. Or excuse me, a net 16, it was 21 and 5, sorry. So overall, to kind of do the math on this one, you can do this whole crazy formula. My plan is in class to not have you do this one here, but I need you to understand why filtration is favored and that pushing happens more at the arterial end versus why when you get to the other end of the capillary bed on the venous end there, why we see generally a favoring of that osmotic pressure starts to win out. And if there was a change in mean arterial pressure, what would that mean for these kind of pushing and pulling forces that we're seeing going on here? And again, this kind of shows you the math that we talked about there. So this blood pressure, your hydrostatic pressures were 35 at the arterial end, 0 for that hydrostatic interstitial fluid. The osmotic pressure was about 26 with about 5 being in that interstitial fluid osmotic pressure. So we saw at the arterial end about a 14 millimeters of mercury favoring fluids being pushed out, where when we got to the venous end, we saw that net filtration pressure was actually a -5, meaning that that osmotic pressure is winning out and drawing fluids back in. Again, this is under normal blood pressure, normal mean arterial pressure of about 90 millimeters of mercury. Again, anything that makes that higher or lower is going to change these numbers. And again, it just shows you that overall we tend to push more fluids out at the blood vessels than we draw back in. And again, that is why we have lymphatic capillaries in place to help make up for that and compensate for that. And it's also part of the reason if you have a removal of lymphatic vessels, you have a blockage of lymphatic vessels, or you have a loss of albumins was another thing we've talked about in class. All those things could lead to edema. Part of the reason of the loss of albumins, if your liver wasn't working well and you weren't making the albumins, that osmotic pressure here, the net osmotic pressure, this is going to be closer to 0. And we're not going to be drawing stuff back in if you don't have any of those blood proteins that should normally be there. And I've said it a number of times already, but because it is not balanced and we do push more fluids out through filtration pressure than we draw back in through through osmotic pressure, the lymphatics have to make up for that. Again, about 15% of fluid is not normally reabsorbed by the capillary. The lymphatic system is picking up that excess fluid and again, returning it to your bloodstream through what we're going to see later on is the right lymphatic duct and the thoracic duct to your subclavian veins right before you're going to the brachiocephalic vein, back to the superior vena cava, back to the heart. So all this fluid that is ending up in the tissues is getting returned to the heart through the lymphatics. Again, anything that kind of plays around with this a little bit can lead to edema. Edema, again, is that buildup of fluid in the tissues. Somehow, if we're not getting good venous return and we're not moving stuff back to the heart, the pressure is building up in those capillaries, we can push more fluids out that way. Other things like histamines make capillaries more permeable. It can lead to that localized swelling, which you get when you have inflammation. That histamine release, where if you have an infection, sometimes it will swell. Let's say you cut your hand and it swells there. That is because those histamines are making those blood vessels more permeable and letting you push more fluids out there. Anything that messes with your capillary reabsorption. So like I was saying, that loss of proteins in the blood through loss of like damage to the liver, other things like that. You're losing these blood proteins. Those can lead to less reabsorption of the capillaries and again a buildup of fluids in the tissues because of that. And again, anything that messes with the lymphatics. So one of the examples of this one, if you've ever heard of kind of the common name is elephantitis. It is this parasitic worm that gets into your lymphatic blood vessels. It can lead to this really large case of edema in the legs or other areas where you have a lot of lymphatic vessels. That gives you that example of a blocked lymphatic drainage. The other thing that happens every once in a while, my grandmother before she passed away, she had breast cancer before I was born. They actually took out part of her right lymphatic duct and some of her lymph nodes in her right axillary region. And if you kind of compared her right arm to her left arm, this one was about twice the size due to that buildup of edema because you weren't having that reabsorption of fluids by the lymphatics on her right arm. Again, too much edema can cause problems. If your blood pressure gets too low and you're not moving stuff around there, you can go into shock. The other thing, sometimes if you build up too much pressure in there, you're going to have issues getting blood to those areas, having issues getting fluids removed, and you can get to necrosis. And again, areas where this can be very, very dangerous. The lungs, too much fluid going in the lungs can lead to pulmonary, well, it is pulmonary edema, but pulmonary edema can lead to inability to exchange oxygen well. One of the last chapters we'll do before the next test, we'll actually be looking at the respiratory system. Normally, you should be at 99% hemoglobin saturation. When you have a pulmonary edema, you're going to see a lot of times that value getting a lot lower. Cerebral edema is another one. We've talked about this a little bit with blood pressure and things that sometimes happen if you're like climbing Everest, for example. But cerebral edema is pushing fluids into the brain. Buildup of pressure in the brain generally leads to abnormal brain function and can be very, very dangerous if it's not remedied really quickly. So that's it for this one. See you next time.